What's up, Performance Therapy Nation? This is Mike Quintons, your host of the On Cue Performance Therapy Podcast. Today we are joined by Dr. Ken Kearns, a board-certified, fellowship-trained shoulder and elbow orthopedic surgeon who specializes in arthroscopic surgical procedures, joint replacements, minimally invasive procedures, as well as upper extremity fracture care from clavicle to the elbow. Today, we'll be discussing sports medicine as it relates to different procedures, common sports injuries, and what brought Dr. Kearns to this field. But before we get into all that, I want to thank our listeners and subscribers for their support as we are officially into season 3. If you haven't already, please go to the bottom of the page on your iPhone, Android, or iPad, hit the 5-star rating, and tell us why you enjoy listening to the podcast. The 30 seconds it takes to do this allows us to get more listeners that have the same interests you do. Your satisfaction in the content we create means the absolute world to us. Now, a little background about our guest today, Dr. Ken Kearns. Originally from Ohio, Dr. Kearns completed his undergraduate studies at Colby College in Maine, where he played hockey, then on to medical school at the University of Toledo, School of Medicine. Next stop, Orthopaedic Residency Program at Thomas Jefferson University Hospital. While a resident, Dr. Kearns was recognized by several orthopedic organizations for his research and leadership. Last stop, Dr. Kearns didn't go far for his fellowship. He was accepted to the internationally renowned Thomas Jefferson University Hospital / Rothman Institute Shoulder and Elbow Orthopedic Fellowship Program. It's a mouthful.
Yeah, it is.
Dr. Kearns has been published in numerous specialty medical journals on topics specifically related to rotator cuff tears, shoulder instability, and shoulder replacement. Philadelphia hand and shoulder since 2016 after spending a few years in New York in a private practice. It is now my pleasure to introduce Dr. Ken Kearns. Welcome to the podcast.
Thanks for having me.
Yeah, that's quite an intro, man. What do you think?
It was a lot, you know. I first thought you were all doing my memorization, but you know,
No
you're not that good.
No, that is very true. I'm not that good. But this is, I mean, you've done so much in Philly. You know, from your residency and playing hockey, you played hockey in Maine, but your residency, your fellowship. So I kind of want to get into your background and education, and then we can move on to some more exciting stuff.
Absolutely.
But tell me about what led to your career path, and what about those experiences that kept you in Philly?
It's so cliche. If you know, so we interview fellows, and you have to read their personal statements, and you read these personal statements, and everyone has the same thing. I was an athlete. I liked orthopedics. I went into it. But mine was not that much different. I grew up originally from Cleveland, grew up in Toledo. Down the street was an orthopedic surgeon. He was a good Irish Catholic man. He had 8 kids, and we all played hockey together. And so we became good friends. My first job was working in his office during the summers, and then my nickname was Dr. Bones. And then so I was like, all right. So he started taking me to surgery in high school. I worked in the front desk. So I've done the hello good window, the goodbye window. I've kind of seen that end of orthopedics. And then I just like, all right, well, maybe this is real. And I was always like, well, if I can't play professional hockey, which is, you know, if you saw me, you'd know that was the likelihood that was pretty slim to none. I was like, all right, I'll do this orthopedic thing. But I was kind of like, all right, orthopedics is a bad rap in medicine. You're not real doctors.
Really? Is that?
You didn't know that?
No, I mean, I completely disagree with that, but I got you.
In the medical world, someone told me this the other day. I was like, well, you know what orthopedics is. You guys are like, I go, you can say it. You're like, yeah, you guys aren't like the real doctors.
Interesting.
So
that's fascinating.
We're considered like, you know, carpenters that work on people.
Well, listen, I've been in those rooms before, and it's like AC/DC's jamming or Metallica, like Kenny G in your case.
You know, you'd be surprised. I remember once with one of my mentors, I won't mention his name because I don't want to offend him. He's a local. But literally the anesthesiologist told him, he's like, doctor, can you please turn down your music? I cannot hear my instrumentation. I was like, yeah, I guess it's important to like hear what the heartbeat's doing.
Oh, but it is like bones flying around, like, but
it's a little bit. But I told someone the other day, I had a patient the other day who was a huge Grey's Anatomy fan. And full disclosure, I still watch Grey's Anatomy. My wife the other day was on, and she was like, it was on her DVR. She's like, are you still watching this? I was like, I know you don't even watch it, so I just deleted it. But yeah, I'm still watching it. And then we started talking to her. He's like, well, what do you think about Callie? I don't know if you watch Grey's.
It's been a long time. My wife's an avid watcher.
Callie was the orthopedic surgeon, and I was like, you at least make us look good. I mean, what she was doing looked so terrible. I was like, there is precision in what I do, but she looks like she's like jackhammering or breaking down a wall. I was like, no, there's actually like fine maneuvers, but So she made it look bad.
Look online. I mean, there are fine maneuvers in what you do. That's for sure. So,
I mean, for any budding orthopedic surgeons, be a good, if you want to tell your parents this is why I would be a gamer, you do have to have like good hand-eye coordination. Because I was trying to tell my wife, I go, all right, so if I'm doing a scope procedure, which we get to do later, but I was like, I'm staring at a screen, my feet are using the pedals, I have one hand on the camera and one hand on the instrument. So I was like, you got to make sure all three work together. And she's like, wait, what? I was like, yeah, I am actually have some ability, I'm coordinated.
The technique and coordination is second to none in my opinion, and a lot's on the line. Maybe it's pretty important stuff.
Yes.
So
we got off track, but so then I was like, all right,
it's gonna happen.
But playing hockey, I've had my fair share of broken bones, and I was like, oh, this is pretty cool. And I saw the surgeries, and I was like, this is pretty cool. And then the more I try to stay away from like being the jock that everyone says that the orthopedists are, I was like, to what interests me, and so ended up, I kind of got into it, and here I am, I guess.
Yeah, so tell me about your time at Jefferson University and your time at with the fellowship. What was that like?
So, for those in medicine, any specialty right now, patients get annoyed, but I try to tell them, I'm like, look, if you go to see your general practitioner and you got to see a heart specialist, they say go see your heart doctor or go see a kidney specialist. So everything in medicine is getting super subspecialized, especially in the two areas I've practiced in now, Philadelphia and New York. You're talking about big cities that they want specialization. Like if you're going to go to a small town, you could probably still see a mom and pop orthopedics, but unfortunately it's a dying breed. It's again a cliche, but the jack of all trades, master of none. So I'm always shocked. Still, people that I respect don't know. They know a lot about a little. And it's like anything. If you don't specialize in that area, you just miss things, or you're just not comfortable with it or familiar with it. But I liked shoulder and elbow because the people who taught me, my mentors at Rothman, you get to be a generalist, but still specialize. So I mean, the youngest patient I've ever operated on, I think, was 12. The oldest patient I did an elective shoulder replacement on was 95.
Wow.
I do. So you get to do kids, you get to do adults, you do everywhere in between. You do trauma, fractures. You do sports related surgeries. From your Tommy John to your instability procedures to, older people like myself and rotator cuff repairs. And so you get to be different, no disrespect to my joint colleagues, but we make fun of them like, oh, you do two procedures, right knee, left knee.
That's accurate. Not how many. I don't know of many surgeons. And I could be completely off base here. I don't know of many surgeons that do joint replacements that also do other procedures such as ACLs. And I think maybe there's a handful of them.
The probably closest is sports. There's some sports guys who do that, but again, sports guys still tend to specialize. Like most sports guys, all right, they tend to probably, most sports guys, at least in my area, are mostly heavy knee. Right. Most sports guys don't do a lot of, they're not usually 50-50 split shoulder knee. It's usually probably 80-20, 70-30.
Right. Would you say of sports injuries that surgery related, that the most variability is in somewhere like shoulder and elbow? You know what I mean? Like it's not ankle, you're doing, and maybe ankles in there too, but is there a wide range of different procedures that you could do in a given day?
Yeah, for the shoulder, you have anterior labral repairs, you got posterior labral repairs, you got superior labral repairs, you've got biceps procedures, then you've got sports related, you've got, if someone separates their shoulder. It took me forever. Honestly, I didn't quite understand the difference between like a shoulder separation and an AC separation. I was like, wait, aren't they like the same thing?
Right.
Until I was actually in medicine.
Yeah.
So when a shoulder dislocation is when the ball comes out of the socket. A shoulder separation is when the clavicle kind of moves. So you do both of those. Yeah. You can do fractures related to those. So there's definitely a lot of variety.
Ton. Did you even say rotator cuff?
Because it's interesting. Most cuff isn't really considered sports per se. It's more of kind of like your weekend warrior. Sure. I can tell you, the youngest cuff I've ever done, and I didn't think he was a cuff. I don't remember if he played college ball, but he was a baseball player, and he was in his 25. He dove for a ball in the outfield, didn't go well. And I was like, oh, you definitely dislocated your shoulder. Let's do some therapy. Wasn't getting better. I was like, all right, let's get an MRI. And I was like, all right, let's just see how big your labral tear is. it came back that he had a full thickness cuff tear. I was like, well, I was not expected to see that.
Interesting, from a fall like that. I mean, it's possible, but it's just not the
Yeah,
most
it's not common. I mean, people
Right.
come in all the time. I was like, I have a cuff tear. I was like, the odds of someone in their 20s having a cuff tear, again, I've now operated on 2 in my almost 10-year career.
Wow.
One was a professional boxer, and then this kid playing baseball.
How about it? All right, so you go through now. Can you explain to some of our listeners, like, how a fellowship is different than a residency?
Sure.
Right.
So, orthopedic residencies, the vast majority are 5 years. There are some 6-year residencies, but that's for research purposes. They usually have a year of research. Some academic institutions have a 6-year program, but a lot of people, it's sort of dying because, unfortunately, people want to. I mean, it's a long process. I mean, I can't remember what I told my my nieces once. I was like, I did 25 years of school. And they're like, wait, what?
It's a lot. It's a lot of school. So one less year sounds a lot better.
Yeah. So people are moving. So it's 5 years of general orthopedics.
Right.
And if you wanted to specialize, I could go through. I think there's 8 subspecialties. And shoulder and elbow is the one that I picked.
Okay.
It just seemed to fit the best for me.
And your fellowship, how long was your fellowship?
So all orthopedic fellowships are a year.
Okay. Yeah. All right, got it. And then from there, you went to New York, private practice up there?
Lived in Manhattan for almost 4 years, and I worked for listeners around this area, that it was like a smaller version of Rothman. There are 45 doctors.
Gotcha. Okay. And came back home.
Yeah, my wife's from the area. She grew up in Havertown, so we moved back when my wife was 7 months pregnant.
So that's a theme on the podcast, a little Delco pride action right there.
Oh, yeah.
Delco comes through, Havertown had to come back home.
Oh, yeah. So, it works out well. We were all set to live in Long Island, but Long Island, it's an interesting place for those that haven't been there.
Good hockey up there.
It was good hockey. It was, we enjoyed living there. My wife had a good job. We liked the city. Although I'll tell you, in like hindsight, I was talking to one of my colleagues who trained in New York, and he's from New York. He just went there Sunday for a birthday, and he was like, I cannot believe that I almost wanted to come back to New York. And I was like, yeah, we're so glad. I could not have imagined spending COVID in New York City.
Oh, that's wild. Yeah.
I mean, we're at a 740 square foot apartment on the 27th floor.
And lockdown.
It just sounds horrible.
Months.
It just sounds horrible.
Awful. Yeah. All right. Cool. So let's go from there then. So you come back to Philly. You have this opportunity now. That's in 2016.
Yep.
And so how long did it take to get into a rhythm? And tell me a little bit about what you do on a day to day.
So I come back from Philly. I joined the Philly Hand Center, which is the internationally known group, because some of my partners are kind of groundbreaking surgeons in the hand world, and there were a couple doctors who sort of did a little bit of shoulder, and Neil Chen is who, he went back to Boston for family issues, and so they sort of had this shoulder void. And when I came back, I was actually talked to one of my buddies at Rothman. I never envisioned coming back to Philadelphia, but I was like, all right, my wife, his family has a house down in Ocean City, and she loves the shore. And I was like, well, let's go live in the shore. And so I talked to my buddy at Rothman, and they weren't in the market for a shoulder guy. They just hired someone, and then he's like, but I heard the Hand Center is quietly looking for a shoulder guy. And so a couple of my partners I was resident with at Jeff, and 3 months later I had the job, and we were back. And so they changed the name. Now it became the Philadelphia Hand and Shoulder Center, because now they wanted to kind of be totally inclusive. And it's good and bad. It took a bit maybe to come back. This is a competitive area.
Sure.
To do shoulder elbow. As you mentioned in the intro, I mean, the Rothman shoulder department is second to none.
Right.
And they're all my friends and colleagues and mentors. So I did give them all the heads up that I was coming back to the area.
That's nice of you.
I try to be kind. They were all very gracious. They told my wife, thank you for bringing Ken back to the area. And as one of my mentors always told me, he's like, you could open up a sign next door. There's plenty of business to go around. We'll all be fine.
That's cool. And I've noticed that even in the PT world, that is something that everyone is very aware of how competitive it is. Yeah. But there's small world.
100%.
It's small world. So
yeah, no reason to burn any bridges.
Amen. Well said.
And so we came back to the area, and then things have just sort of naturally. I don't know. I'm not good at marketing myself. I've never, Lori, she'll probably hate me for saying this, but it's like, oh, you got to go and meet people. I just don't. I don't know. It's hard for me to It's like, so for me to sell myself, it's like, all right, well, that guy sucks. You should see me. I have a hard time saying that. So I'm kind of like, I don't know. I think I'm good at what I do. You know, it's always like one of those, like, well, what separates you? I go, I don't know. I try to tell people all the time, I'm like, this is what I do for a living. It's not who I am. So I think some people just like my personality because I'm not your quote unquote typical doctor. You know, my dad yells at me, I'm supposed to dress a certain way, I'm supposed to shave, all these things that I don't like doing. But I just like, I guess I am who I am, and hopefully people like it. But so then it's organically I've grown my practice, which I think is probably the best way to do it.
Heck yeah, amen. Well said. I think it comes down to I get the marketing piece. That's something that we have to do in PT.
It's just hard to sit there and go to someone like, don't go to that therapy group because, you know,
exactly.
Come to me because and they're like, well, what do you do? Well, because you have to knock someone else to almost sell yourself.
It almost, here, we can dive into this for a hot second because this is relevant. In physical therapy, at least, and the same goes for you, when you walk in to meet somebody, they want to know, okay, why are we sitting down talking right now?
Yeah.
Well, because I'm a physical therapist and I have this practice and, you know, I want to help your patients. It's like, all right, this is someone else who wants something, wants me to send them, you know, patients, or wants me to buy their device or whatever the heck. And it's salesy, and it's...
And I'm not a good salesman, no.
Well, it makes me uncomfortable because now I feel like you want me to go.
Right, 100%.
I don't want to bother you.
Right.
But in the end, you know, and this is taking a lot of reinforcement and meditation and praying that in therapy, other types of therapy, that you know, you're offering value, right? And that's the tough part, and it doesn't make it easy. There are times where you can kind of see some body language. You're like, listen, I get it. You're busy. We'll talk another time.
Well, it goes both ways. You know, if someone comes in to this building to sell you something, you're like, I'm busy, man. I got things to do. Like, let's, you know. So it's just, it's uncomfortable. And some people, like, that's their thing.
Some people love it.
I'm fine with it if that's what you. I don't know. It just makes me uncomfortable.
I'd rather not if I don't have to.
100%.
Right. But like having a casual conversation with you about, you know, like, what do you see? I want to learn more about you as a person. To me, that's fun.
I'd rather do that.
Right.
Well, I tell people all the time. My assistant will yell at me. I go, she's like, "You're taking too long," and I was like, I don't know. I mean, the medicine to me is somewhat straightforward and easy. So I'd rather sit there and bullshit about anything that's of interest in your life. I mean, gosh. Today I spent half the time. There's a woman who has, she's a medical condition that's somewhat similar to something my wife has with their stomach, and we spent 15 minutes talking about that. I don't know. That was interesting to me.
Sure. Well said. I think people get stuck in this, like, this is a medical practice. I got to do my job. I got to check my boxes. I got to get my documentation done. I got to move on. But that's not fun. Like, I mean, it's fun, but it's not that.
Well,
fun.
you know, there's certain.
Stuff.
I'm sure it's the same for you. There's certain patients that come in that you know, like, look, you see them well enough, you can read their face, they want to have a conversation, and you're like, look, this person wants to BS, and it's enjoyable. And there are certain people who come in and they just want to do their thing, and they are not in the mood or in the time to sit there, and you're like, all right, they can get in and out. So you can sort of make up ground for people you talk with and people that don't want to talk to you. So that's how I sort of try to judge it.
No, but you got to enjoy it. I can tell you love what you do. You're passionate about it.
I like the people.
It's the people. I agree.
I like the people because my wife doesn't think I talk about it at all, which baffles me because I wish you could like listen to this, because I was like, everyone comes in like, how are the kids? Let me see the pictures. Like, people follow my kids, and like people haven't come in a while, like, oh my God, they've grown so, because I have a 3 and a 5-year-old, and they're like, oh my God, they've grown so much. And I was like, I sit there and brag and I show pictures, and again, she thinks I almost act like I don't have a family, which I don't know. But I don't know what that says about what she thinks about me outside. But she also,
I get it.
She doesn't think I can be serious either. So apparently she thinks that she's like, just wants to watch me work because she doesn't think I have a serious bone. I was like, I can be a professional. I just don't outside of work.
Good for you. It's good to be transparent about it.
I try to be. I told the patient this today. I was like, I try to be as honest as possible. She's like, you weren't lying. I was like, oh, well, I mean, does you no good? I'm not going to lie to you. I mean, you know, you have to have some rapport and confidence, respect who you're seeing.
Well, that separates you. I mean, I think that separates any, especially an orthopedic surgeon that has that kind of personality. Because the reality is, and you know, I'll probably get get shunned for this. Not all orthopedic surgeons, like PTs, have great personalities.
You know
what I mean? Doesn't mean they're not good at their job. Listen, some of the best ones, you can probably attest to that. Some of the best ones probably aren't the most people.
I mean, again, I won't mention names, but we have a close family friend who he does commercial real estate in Cleveland, and he can do things that the average person can't do. But I still remember we were talking about he had to get his hip done, and he was asking for suggestions, and I talked to some of my buddies in Cleveland, and he's like, I'm going with what I'm told is the best hip surgeon in Cleveland. He's like, he's a complete a-hole from what I've told. So I talked to my friend. My friend is like, I'll see you before and after surgery. He met the surgeon. Literally, he said hi when he signed the consent in the holding area, and he never saw him again. And he's like, look, I've heard he's an amazing surgeon. I don't need to be friends with him. I don't need to see him again. And I was like, well, hey.
I say it all the time. We get asked that all the time. What do you think about so-and-so or so-and-so? So listen, I've heard bedside manner may not be the best, may not be their forte, but they're damn good at what they do. Yeah. So, make a choice.
Not to sit there and say we're not talking marketing myself, but if I'm going to market myself, I mean, that's the difference between me and like, I feel like I can bring both to the table. Sure. So at least I can hold a conversation and be personable.
Well, and some people want that. When they walk into the room, they want to be heard. Because I've been in those rooms where there's no eye contact, looking at a screen, not listening to the patient. Maybe they are listening to the patient, but there's no eye contact, and they're just looking at an image. Like, okay, so this is what's going on. You have a whatever tear, and this is how we're gonna fix it for you. So we have openings, next Tuesday or Wednesday, and we'll just get you scheduled.
I signed a guy last week. Literally, he didn't even tell me who he saw. He saw another doctor, and he came in. He's like, he's honest. He's like, he didn't tell me how honest, but he said, I'm just here for a second opinion. I said, okay. I said, and I was telling him, I don't want to know what he or she told you. I kind of want to, I don't want to be biased. I said, so I went through, I did the exam, I looked at the MRI, and he had a cuff tear. And I talked about, why the pros and cons of fixing it, the rehab, the recovery, all that fun stuff. And he's like, all right, I don't want to have surgery with you. I was like, okay. He's like, yeah, the other doctor, he said kind of the same thing, but you explained it way more. You actually had a conversation with me, and I just like you better. And I was like, okay, great.
So why? Where does that come from for you?
The backstory is, and I don't remember. I almost have to ask my mom. There actually is a story, and I'm sure I think you told me. I can't remember if it was a son or a daughter.
Daughter, yeah.
So your daughter. Yeah. So I'm sure she's already getting the personality at her age, and obviously, my kids. I can tell my kids are 3 and 5. I can already tell when they're in a mood or they haven't eaten or whatever. But I guess I'm very moody. My wife will agree with that. And when I'm annoyed. And so I don't remember why. We went to a doctor's office, and this was when I was thinking I wanted to go into medicine. I want to say I was in high school. I don't remember again what I was seeing this doctor for. And apparently I shut down. And when I shut down, it's usually because I'm pissed off. And we get outside, and my mom was like, you didn't like that doctor, did you? And I said, no. And she's like, why not? And I told her, and she's like, I feel like he talked down to me. And I guess, real quickly, I mean, something I try to do when parents bring in kids, even if the kid's 5 years old, I talk to that kid.
Love that.
That's the patient. Not the parent's not the patient, the kid's the patient. I'll answer the parents' questions and sure. I'll engage with them, but I talk to the kid because, you don't need to talk about them. They're right in front of you. So I talk to them. And so I think it was something similar like that. My mom's like, just remember, if you end up becoming a physician, don't ever treat your patients like
that's
that.
That's cool that mom brought that up.
Yeah.
So. That's a cool lesson that, she had the perspective and wherewithal to kind of bring that up to you afterwards.
Yeah, I mean, and we train fellows, and so we have a large fellowship program, so we have 7 fellows, and so I always tell the fellows, I'm like, look, you might have given this conversation 1,000,000 times, but the person across the table, it's the first time they've ever heard it. So you've got to remember that they've never heard this before, and so you got to sit there and take the time and answer their questions. And you got other patients waiting, and you got things to do, but again, they're scared, they're nervous, and you want to make them feel comfortable.
Yeah, sensitivity to what a patient is going through in their lives and everything they had to go through to get to that spot, the chair in front of you.
No, 100%.
And they're making a big decision.
100%.
It's going to impact their lives for a long time.
Yeah, I mean, again, it's I don't know. Again, my wife and I had this conversation yesterday in the car, and I was like, it's hard to explain if you don't do it. But medicine's very different because you're actually, there's nothing wrong with or different or nothing less of, from fixing someone's home or fixing someone's car, but when you're actually working on someone else's body, that's kind of an intimate relationship, and they got to trust you. Again, it doesn't have to be a surgeon, it could be a therapist, but you're helping them get better. It's just different. And if you don't do it right, or if you feel like you messed up or you're wrong, it's hard to, I tell all the time. Gosh, I couldn't tell you, any patient, and I love when patients tell me that they're doing well. Those are the patients I remember. I remember patients that aren't doing well. or if I don't feel that the surgery was 100% perfect. Those are the ones that just, bog my mind.
I can count on one hand the number of times a patient has walked out of the clinic, like completed their treatment, their visit, and I was like, I wish I had time to do like this, just one more thing with them.
Yeah.
And again, I think I'm fortunate to say that's only on, one hand how many times that's happened, but that's not a good feel. And I can probably name each time. Like I would just, people showed up late or early and it was just a chaos. And, and it's like, I know they're hurting right now and I want to do one more thing with them. That's not a good feeling.
But I remember like my brother and I were into like the whole, like, when Texas Hold'em was like, kind of a hot thing for a while. But I remember, I forget which gambler said, he's like, I couldn't tell you any of the times I won. I can tell you every time I lost.
Yeah, right. So, hey, remember your losses, not your wins.
100%.
I get it. So let's get into your practice a little bit. So what are some of the common sports injuries that you see?
I mean, so again, I specialize in shoulder to elbow. So, sports injuries, you see clavicle fractures, you see shoulder instability, you see AC separations. You don't really see too many proximal humerus fractures in kids. Occasionally you can. So again, labral, so now it doesn't have to be shoulder instability, you have labral tears, so people think of, there's anterior and the posterior labral tears, there's a slap tear that people talk about, that's a lot of overhead throwers, so you deal with all that fun stuff, and then if you're gonna kind of work your way down to the elbow, you've got your Tommy John, which is the ligaments on the inside of the elbow, you've got the ligaments on the outside of the elbow. Not sports injuries, more for the weekend warrior. You don't see too many high school, college kids, but you get distal biceps tears that I deal with. And then you have fractures around the elbow. The one you usually see for kids is the medial epicondyle fracture. So those are the ones
the good old little league elbow.
Oh yeah.
Yeah. So what? How would you? Is there an injury that is more prevalent now than that wasn't very prevalent, 10, 15 years ago, that you see in the office? Damn, I'm seeing a lot of these lately.
Honestly, the one that's probably more that you can think about, but we talk about all the time, is probably more the Tommy John. Yeah. I mean, I remember once, I was back in the area somewhat recently, and there was a kid, because the difference was, and I don't know if there's a right or wrong, but when I grew up, I played hockey, I played baseball, you had a team you played on. There wasn't 3 teams you played on. And now you see kids who play literally all year long, and that's all they do. I mean, so this kid I saw, is the first kid I saw who had he tore the ligament on the inside of his elbow, his Tommy John ligament, the UCL, and he wasn't even skeletally mature yet, which I was like,
that's wild.
And he was 14 years old. His dad was the coach. They had a mound in their basement, and he threw all the time, every day. And it's just like, I still remember once that James Andrews, who's kind of like, a lot of people know his name. I watched him give a talk once and he kind of, as he said, he's like, your arm is not designed to throw a baseball. It's just not. So it's gonna break down. And, in theory, you only have so many throws in that arm. And so it's like the amount of times that kids throw a ball, like, unfortunately people just think like that's what's gonna get you there. I mean, people forget, whatever you believe in, God-given talent, or just natural ability, I mean, that's what's going to get you there. I'm not going to say that you can't work hard and get there, but the vast majority of these athletes, and my brother played professional hockey, I mean, he'll tell you there, the guys, the stars of the team, those are just the elite players. But the average player, they're just all good. They just happen, everything sort of fell into place for them.
Right.
But it's not from playing on 12 teams, all year long.
Why? And you've seen it in this area in particular.
100%. I get it's just
wild.
I mean, even I don't know if you've seen it. I was shocked. I remember even some kids were starting to throw weighted baseballs. So could throw. I go. A baseball's bad enough. Don't throw a weighted baseball.
So what happens is, and this is just my perspective, in my opinion. What happens is that parents, kids, more often than not, parents or kids, more often parents see something online or on ESPN, documentary, and this, baseball player who was injured and made a comeback, had Tommy John surgery, and he used weighted baseballs, and he's throwing harder than he ever has. And then, I get it in the clinic all the time. Hey, what do you think of J-straps, or what do you think of, or J-bands, or what do you think of, weighted baseball throwing? And there's been research on it. James Andrews, Kevin Wilk is one of the main PTs for James Andrews. I've watched James Andrews speak as well as at some PT conferences. And some of the research that's come out has said, if you throw 10 out of 12 months of the year, you are 10 times more likely to experience Tommy John tear, UCL tear. It's wild. He said he's got 12, 13-year-olds waiting at his door, like when he gets to work, to like trying to get surgery, and they think they need it, or because everyone throws harder afterwards.
Well, that's the crazy thing. The fallacy is that people think that they do better, and if you actually learn the literature, there's only about, well, first of all, you only hear about the big name players, and I tell people all the time, and you probably tell your patients, is two things. One, if you really look at the literature, probably only about 60% of patients actually get back to their pre-injury level.
Yep.
You don't hear about the high school player who never plays again. You don't hear about the college player who never plays again. You don't hear about the minor league player who never plays again. You just think like, oh, that one guy, he throws harder. Still to this day, people ask me like, well, I'm going to throw harder, right? I'm like, no, you're not going to throw harder. I hope you can throw as hard as you used to, but like, let's be realistic.
Manage your expectations here, right?
Yeah, and then the other thing I try to tell them, I was like, look, you got to remember, they're a professional athlete. That's their job, and they have you
resources.
They have you next to them 7 days a week,
right,
24 hours a day, doing therapy, because that's his job to get that guy back on the field. You might be a great high school player or a great college player, but you don't have 24/7 therapy because that's not your job. And so it's just different. You don't have all the luxuries that they have. So you're seeing your therapist 2 or 3 times a week, and so
yeah, it's tough. And then it's communicating between different. In that environment, you have the trainer and you have the PT, and everyone's in the same room essentially. It's very difficult.
Yeah.
I can tell you firsthand. And this environment where you have 5 different coaches. You got a pitching coach, you got the baseball coach, you got the other baseball coach for the travel team, and then you have the little league team. Yeah. It's a lot of hands in a cookie jar. So to
I mean,
speak.
you've probably seen them. I mean, again, don't get me wrong. I think things have changed probably for the better. I mean, if those that listen and sit there and watch some of these ESPN documentaries. I mean, back in the day on the flights home, they'd drink beer and have steak and smoke cigarettes. Nowadays they got their protein shake and so things have obviously improved in terms of nutrition, and then in terms of technique. I mean, you now have these analytics of showing like proper throwing techniques. You can kind of do all these little ball things and see your mechanics and make sure you're doing it right. So things have actually obviously improved, but it's just you've taken that transition again, like everything. You have to do it to exhaustion. So people now, again, you don't have the person who plays, oh, I'm going to play on like the hockey team, and I'm going to play on the softball team and the football team.
Yeah, specialization happens so much younger now.
Crazy.
And the awareness is there, but the pressure's there too.
Well, everyone's got to be on this elite team. You can't.
And if you don't play the team in the fall, the baseball team in the fall, then we can't guarantee that you're going to make it in the spring.
Then you're done. Yeah.
So I got to play in the fall, I guess.
So that's probably. I mean, again, these arms just aren't made to do some of this stuff. So I'd probably say elbow injuries or overuse injuries are probably the most common thing I see.
Okay, so in shoulder procedures, I'm curious about labrum, right? Because there are a lot of asymptomatic labral tears out there.
100%. I think I have one. I mean, I think I have a labral tear on my left shoulder. I try to tell people all the time, like, you don't need surgery in every labral tear. I think I have one on my left one. I've never been proven, but I get some crunchiness and it hurts. And outside for when I try to really lay into a drive, which really hurts sometimes, it doesn't really bother me.
Okay, so I'm curious, what do you see? Like, what are the clinical, what's a clinical presentation, right? Or even the subjective presentation, if that matters.
I mean, they're pretty variable, but I tell you all the time. First, you got to remember your shoulder joint. You have more motion in your shoulder than any other part of your body, and your labrum is the structure that sort of surrounds the shoulder that helps it helps increase the surface area of your shoulder, that helps increase your stability. But it can be so if you're talking about the anterior labrum is 99.99% of the time, your anterior labrum is what's involved in shoulder instability. So if you dislocate or subluxate, where your shoulder kind of feels like it falls out of, pops out and goes back in, or a formal dislocation where you have to go to the emergency room, have it put back in, you're tearing the anterior labrum. Like, you don't have to get an MRI. We know it's torn. It's just the question is how much is torn. So that's kind of like an anterior labral tear will present itself. A posterior labral tear is slightly different. We always talk about like it's like if your arm is going backwards. So it's we always talk about like football linemen who, if their arms are going backwards, or if you fall forward with your hands outstretched, that's where the shoulder's going back. You can get a posterior labral tear that way. Sometimes I'll see kids in the gym, they're really trying to put up some big weights, and they're like, I felt something tear. I was like, oh, I wonder if you could have a posterior labral tear. And then with like the superior labral tear, that's usually like a throwing athlete. So the classic is a pitcher or someone in the outfield. They talk about they have one throw and they're like, I just felt like it just didn't feel right. And again, the shoulder dislocation is pretty obvious.
Right.
The other ones can be a little bit more subtle. It's just pain. The superior labral tear, you'll have a pitcher who will be like, I just feel like my velocity might be off, my accuracy might be off. But again, they have pain, but they can still throw the ball. That's sort of like the vague one where you've got to, again, the superior and posterior labral ones, like it just hurts. It's not like it's unstable.
I would imagine that it can get difficult to, structurally you can help fix what the problem is, or at least, minimize the amount of issues that individual's having. But if they want, if they're like, all right, I think I really need this like procedure done. I can't perform the way I used to. What else can I do to get this fixed? And you may see them like, if this person was 10 years older, I wouldn't touch this with a 10-foot pole.
I mean,
I don't know. But how's that? What is that like for you? Like, what goes through? What do you think about
here's what a couple things. One, I try not to play the age game because it's like everyone is. I don't think it's fair because for like cuff repairs, a lot of people are like, oh yeah, I'm not going to fix a cuff tear on anyone over 60. I was like, why? There are some people who are 60 that act like a 40-year-old. And there are some people that are 40 that act like an 80-year-old. So, I mean, I think you got to treat the person, not really. I don't really go like so dogmatic about the age. But we briefly talked about this before we started, but I don't look at my job as to tell someone what to do. There are very few indications where I said, you need surgery. I mean, if I think it, I'll tell them. But I look at my role as say, look, this is complex stuff. I've studied my whole life for this. This is what I do for a living. You don't know anything about what we're talking about except for maybe what you read online, and often that's the wrong thing.
Right.
So I try to say my role is to help you make an informed decision about what's best for you. So I'll sit there and I usually explain, what the underlying pathology is, the pros and cons of surgery, not having surgery, conservative management, where therapy fits in, because despite what people often say, and I don't know what you hear on your end, is like therapy can work. You can get better, with therapy. Not every single person needs to have surgery.
Yeah.
So I sit there and I just try to go through them, and I would say, what are their expectations, what they're looking for. And I tell people all the time, one of my lines, I'm sure you have lines that you get sick of hearing yourself say, but one of mine is like, look, you can sit on the couch all day and probably be perfectly fine. But if that's not how you want to live, then there are things that we can do. My job is to get you back to do the things you enjoy doing, whatever that is.
Yeah, you nailed it. I think that's very well said. Is there anything you look for on an image where you're like, that's gonna need it, and how much do you depend on the image versus the presentation?
So I usually have an idea of what's going on. Like we have a family friend who I was treating off the books this summer, and she played college softball, and I was like, I think you've got a superior labral tear, and so we did all the non-operative stuff. She did therapy. I gave her an injection, and then I said, and she was like, all right. I usually tell people, look, the point of the image is not to confirm what you have. The point of the image is because you failed conservative management and we're discussing surgery, and the image is going to help me surgically to explain how involved the surgery is going to be.
Sure.
So usually by the time we get the MRI, I already know what's going on, or at least I think I know what's going on, and it's just confirming it because we need surgery and let's discuss what we're going to do. So to me, I don't really use the imaging. Sometimes you're like, I just don't have a clue, and like this, let's get the MRI and let's see what's going on. The problem is, I don't know if it's on your end as well. The problem is, again, in today's day and age, people watch SportsCenter and they get confused. They see like, he got hurt, he has an MRI. I'm like, that's not how the real world works. It's different with a professional athlete because, again, you're talking about millions and millions of dollars, and the MRI doesn't cost them anything. The average person who's got an insurance company, their insurance company says there are certain things you have to do before you can get an MRI. So you sort of got to, I tell people all the time, I'm like, I work at the parameters that the insurance company allows me.
Right, and so do we. So for us, and probably same for you, an MRI supports the procedure you're about to, it pretty much tells the insurance company, hey, listen, this is what's going on. This is why we're going to fix it,
right,
because of what this image says.
100%.
Yeah, and there are asymptomatic findings all the time, right? You may find, okay, this person is presenting with a, their infraspinatus has to be like they can't even hold their arm up, right? Like it's just dropping. They have positive for drop arm, but it comes up that there's a labral tear, like I get that there's a labral tear there, but that's not even, we can't even get to that being an issue because you can't lift your arm up high enough to impinge on that. So
well, I told my friend today because she called me. We went over MRI on the phone today, and I was like, oh, she does. She's a superior posterior labral tear, and I was like, oh, she's like, yeah. So you kind of know what you're talking about. I was like, a little bit. And she's like, what about my clavicle? I go, forget about your clavicle, because it said that her clavicle was lighting up. I go, any person who is an athlete who works out, their clavicle is going to light up. It just does. The clavicle is probably the most common thing. There's two things that we see every time: the clavicle and the superior labral.
And what do you see with the clavicle when you say light up?
Oh, it lights up because of like osteolysis, meaning there's anyone who bench press. Like I always tell people, look, in full disclosure, I do these things, so I'm not telling you not to do them. But the worst things you can do for your shoulders are bench press and shoulder press.
Yep.
Because it's a horrible stressor, and so when the clavicle quote unquote lights up, it just means there's inflammation in the clavicle. But just because an MRI shows it doesn't mean it's actually the pathology.
Right.
So I think that's the difference where you need someone to kind of be like, all right, yes, the clavicle lit up or the superior labrum lit up, but it's your rotator cuff. That's the issue. It's not, don't forget about that stuff.
So correct me if I'm wrong, it seems like you gather a majority of your diagnosis comes from what you do in the eval room, right? What you find clinically and their history, right?
Well, one of my mentors, and one of might be a line on my page because I think I've said it before, is one of my mentors said it, 90% of your diagnosis will come from what the patient tells you. If you just listen.
It was on there.
If you just listen, they'll tell you like what it is. They usually will give you the clue. And then you do your exam and it kind of confirms it. Now, you still have, I had a woman today who I think she was a little upset with me, but I said, look, I don't know what's going on, but her MRI was normal, her nerve study was normal. I'm like, every test has been normal. I'm not saying you're not having pain. I just don't have an answer for it. And I think that's okay to say you just don't know.
Amen. Thank you for saying that. I say that all the time. I'd rather tell you I don't know. Like, I'm sure you hear this all the time. When can I get back?
Yeah.
Like, you already asked your physician. Now you're going to ask me. I'm going to tell you the same thing I hope your physician said. I have no idea.
Yeah.
But when I do know, you're going to be the first to find out. I mean,
Yeah.
I'll tell you. But for me to put an unrealistic expectation out there isn't appropriate. For you to make up some,
and it's hard.
diagnosis, that's not fair.
I think there's the misconception that, and I'd love to say that, like, I think that we're really good at what we do, from like the surgical side to the therapy side, but in the reality of the situation is not everything that goes wrong you're going to get back 100%. I mean, I tell people again, the cliche of the orthopedic surgeon who hurt themselves, and that's how I ended up in it. But I broke my wrist when I was a freshman in high school. My wrist has never worked the same ever since. I have limited range of motion. It hurts. And I was 15 years old, and I didn't have surgery. So, I try to tell people, look, I had age on my side. I didn't have surgery, but it's never been normal. My job is to get you as good as I can. I don't guarantee you're going to be normal. And I think sometimes people forget that. They just think like, but what can you do? And I was like, unfortunately, it's, again, whatever you believe in, you're as good as you are when you're born. And my job is to try to help you get back, but it's hard for me to make you perfect.
There's so much that goes into it mechanically from even like a neuro perspective. I'm sure you deal with that a ton with the shoulder. I mean, you clear the neck, right? You got to clear the thoracic spine. It's not
well, I'm sure it's the same for you. I mean, you get someone who has an ACL by the same surgeon, probably done the same way, and you're like, you do that. You have your protocol, and you do it, and you're like, you have, kid A who does amazing, and kid B does fine, but he's not as kid A, and you're just like, I don't know. I wish I could explain it.
It is interesting, right? And some people are more lax than others, and so forth. So before we got on air, we spoke about some new research that's out about shoulder instability. So I would love to hear about what your take is on what is the literature saying now, and what is your take on it, if you don't mind sharing.
Yeah, so there's a little bit of a shift. So there's some literature, again, that it goes a little bit black and white. It's not taking the patient as a person, but it's kind of stating that there's some literature, it goes like it's cost-benefit analysis, and stating that, so historically speaking, you used to say like, all right, after your third dislocation, you call it like a third-time loser, all right, you should have surgery now. You failed conservative management, you have recurrent instability, let's fix it. Now, what that doesn't take account into is that every time you dislocate your shoulder, there's a variety of things. One, it hurts. You got the expense of going to the emergency room and have it put back in place. You have the actual trauma of what's inside the joint. Every time you dislocate your shoulder, you're causing more pain or more damage to the joint, and then you're out again. So if it's if a kid who's playing high school football who dislocates his shoulder and he misses half that season, and then he dislocates it again and he misses the rest of that season. It's like, all right, well, that's 2 dislocations. We'll rehab him, and then he comes back the next year and he dislocates again. He's now missed kind of 2 seasons. So if you really think about it that way, I'm like, all right, so the cost benefit analysis, like, well, pretty costly to not have your shoulder fixed. So what they looked at, they said any teenager who plays a contact sport should have it fixed after first time dislocation.
And if they intend on continuing to play that contact sport,
Correct.
or even if they don't intend,
No, if they
imagine.
intend, yeah.
Okay.
I mean, because the odds are, if you don't, because what studies show is, like, if you don't fix that kid, he or she is doing something that puts him in that position to a contact sport. So the odds are it's going to come out again. And so
that's interesting, and it makes it. We see it all the time, that where they didn't undergo a procedure. Usually that's like a 3-time loser, so to speak. But is it because the capsule is lax and that's not something we can?
Well, I always tell people
we can repair, right?
Without getting too much into like the getting lost in the weeds. But I tell patients there are 2 things that keep your shoulder stable. You have your basic anatomy, your static stabilizers, and you have your dynamic stabilizers, your muscles. So once you damage the shoulder, dislocate it, you've torn those static stabilizers. Those are not fixable. They do not heal themselves. People always ask, nothing in your shoulder heals without surgery. It just doesn't. It scars in, but it never will go back to where it was. So when you tear your labrum, it's not really the labrum that you worry about. Now, the labrum is a little bit of a buffer, or this kind of like a cushion of the shoulder.
I call it the washer, like between a nail and wherever you're putting it. Like, it's the washer. It's got it.
I could use that. Maybe I'll steal that. But it's the ligament that attaches to the labrum is what gives your shoulder stability. I always tell people it's like a hammock effect. And so what happens is you lost half your hammock, and so when your arm's up, you fall out the front of the hammock again. But once you tear that, it never goes back to the tension that your body was designed to have without surgery. So you can't change that, but what you can do is you can change the dynamic stabilizer of the muscles, and that's why I tell people therapy can be helpful. So there are plenty of patients. I had a 21-year-old kid today who had recurrent instability, never had treatment, and they were definitely on the side, and I could read them pretty quickly, of like the non-surgical side, which I told them was fine, because I gave them the talk I just talked about, like the pros and cons, the risk analysis, and the odds are he should, the literature suggests that you have surgery, but just because that's what the literature states, you still have to treat the individual.
Also.
And so they they understood, but they we would like to try therapy. Now I also state, and I don't know what your feeling is I tell people all the time, like, look, you don't have to do 4 to 6 months of therapy. Do it for 4 to 6 weeks. You're gonna know either A, I'm feeling better, and then we can continue down that path, or B, I don't feel a difference. And I say, look, if you're feeling better, then we stick with therapy. If you have no difference in 6 weeks, the odds of 6 more weeks or 3 more months of therapy probably isn't going to help.
Well said. No, I agree. To me, you should be in therapy for the time it takes to observe a minimal detectable change, right? If you only stay for a week, well,
it's not
gonna see it, right? But if 6 weeks leads to it, is enough time to typically see it like a minimal detectable change, some change.
Right.
Then at least stick through that process and see if this is going well for you, unless it's something that's out of anyone's control that you just don't like about the place.
Yeah, this kid came back today and he was like, I feel amazing. I haven't felt this good in 3 years, and I was doing things I haven't done. I was like, awesome. I said, as long as you stick with the program that the therapist taught you, you'll be fine. Because again, those are you need to keep those dynamic stabilizers in check, and if you don't, then you might be here with a dislocation.
Right, interesting. So when you go in for a repair of some kind, what exactly are you fixing, right?
So what you're doing, and I guess
the hammock, are you fixing one of the pieces of the hammock?
Right. So again, the ligament. So it's the anterior inferior ligament is what attaches to the labrum. So what you're doing is we have to, usually it falls down, and so you have to lift it up. So you have to lift it up, and you want to see the normal tension on the ligament. So that's what you're doing. You're really pulling up that labrum, and you're using anchors, and there's a variety, there's different types of anchors you can use, there's different types of techniques, but the bottom line is you want the labrum, you want normal tension on that ligament, because that's what's going to keep the shoulder stable. If you just put the labrum where it's at, and you don't get the normal tension on the ligament, then it's all for naught.
How do you determine what normal tension is when you're in the?
I think it's one of the things with experience. You got to know it has to look normal for you, because if you the first part of any shoulder arthroscopy is a diagnostic scope, and so every shoulder scope I do a diagnostic arthroscopy. And so I think it's one of those things when you do enough, you see enough, it's kind of, you know what it looks like.
Yeah, and the same thing goes with PT. You know, when you're mobilizing someone's neck or their back, and you're like, yeah, no, it's a feel. I can't tell you what that.
It's hard to explain.
The degree of stiffness.
100%.
You know, so all right, so that makes sense. Because I've always wondered, like, how do you measure? Like ACLs are doing that now too. Like they're measuring the amount of tension on the graft or whatever they're using as the ligament, you know, reconstruction. You know, what is normal, right? Like, do you want it to be symmetrical? Do you want, you know, is there a certain number you're looking for? So more by feel in that case.
Yeah, I think it's one of the things you got to know what it feels. But again, I think that you want that quote unquote bumper that people talk about, but that's not what's keeping the shoulder in place. The bumper is obviously helping, but it's really the ligament. The ligament has to get back to get that hammock-like appearance, or the shoulder's going to fall right back out.
What kind of recovery would you expect, like Baker Mayfield, for example?
Yeah, my kid from Cleveland. You know, I told my dad the other day, because I told him, I'm like, he's out 4 to 6 months, and he sends me an article from the doctor he saw. I said 4 to 6 months. I'm like, yeah, I know what I'm talking about. I know my family doesn't think I'm a real doctor. I don't know what they do. I think I am, but no, they don't believe what I say.
I'll ask you what your opinion is, and then they won't.
I usually say, for again, you know, you can. I think we push the envelope sometimes. I don't know if you get kids. I'm having a mental block right now. Who is the running back with the ACL?
Adrian Peterson did it in like 6 months.
Yeah, because you know, pre-Adrian Peterson, you know, it was a year and a half. Right. Adrian Peterson come back in 6 months, and all of a sudden everyone changes their ACL part. Okay, well now it's 6 to 12 months.
Put a pile of sand in the backyard so they can run up the hill.
So, but I think that's kind of what happens. Everything. I mean, rotator cuff repairs used to be everything was like you're 12 months to a year and a half. Now most cuff repairs people say, well, 6 months. I mean, that's what I tell them. The smaller tears, I say 6 months. The bigger ones, I'll say, you know, 6 months to a year. For labral repairs, I usually tell people, I say it's 4 months for when you can do whatever you want outside of contacts. I usually say no contact sports for 6 months.
Got it. Okay. So how's Baker Mayfield going to be able to play this year?
So again, obviously I haven't seen Baker Mayfield. I haven't seen any of his studies. The good news for him is his non-throwing arm. Now again, you're talking to someone who's never played football in his life. So I'm trying to think of like, I don't think it necessarily affects his throwing. I don't think. Now again, I don't know throwing mechanics enough to know what your lead arm does, but I don't think that's really it is. I think it's, you know, him trying to, one, defend himself or being sacked or tackled. I mean, that's obviously where it's going to fall. And every time, the article I read that my dad sent me, I don't remember where it was in, sounds like his shoulders came out 3 times.
Yeah.
So he's already proven, whatever factor you want to go by, he's a 3-time loser, and he clearly needs to have this fixed. The question is, can he get through the year? And it goes back to kind of what I tell kids in the office is, you know, I ask them all the time. I said, what are your aspirations for sports? Whether it's high school and you want to play college, or if it's college and you want to play after college. Because if you're gonna have surgery, we sort of have to try to figure out around your season, your life. I mean, if it's a high school kid who plays 2 sports, I say, look, is this your number 1 sport or something else? Because if it's something else, I'm like, all right, well, let's do it now. But if this is your number 1 sport, then all right, we'll work around the season that's not your number 1 sport. So I think with Baker Mayfield, it really comes down to the Browns are how far, 1, can he play and be effective, and 2, how far can they go in the postseason? And if they're like, if the Browns start struggling, then I guarantee he's gonna have surgery immediately. And you know, with what's his name, how he looked last week, they might say, well, you know, maybe we'll be all right. He didn't look terrible. But the good thing is it's non-throwing arm. You can wear some of these harnesses, these Sully braces that people wear. But the problem is, I had a guy on my hockey team in college who he played in a Sully brace. His shoulder popped out pretty much every game. I would love to see what his X-ray looks like, right? I mean, he's going to get a shoulder replacement.
Who's relocating?
I don't know. It pops out so much he does it himself.
Oh God.
Yeah. But the problem is, no one likes it, so they loosen it up to where it's comfortable, and then it's no longer effective. So that's the problem. Yeah. Right. So all these braces, they're only as effective as if you wear them properly.
So I'm curious about AC joint, right? So the ball and socket, the glenohumeral joint, is a dislocation, right?
Correct.
So the AC joint, which many call, you know,
shoulder separation,
right, is where, you know, these 2 bones, your clavicle and your acromion, come together. The acromion comes from the scapula. Yep. And obviously you have the clavicle. Now there are ligaments, you know, all around it. There's obviously the one ligament that connects.
Right. So there's like 3 ligaments kind of keep it all together.
Yeah, and you have the two that come from an inferior angle a little bit more so.
Yeah, so you have your CC ligaments, your
Yep.
corner, and your trapezoids that come from, if you're ever pushing on the front of your shoulder and you feel like a bone sticking out, that's your coracoid.
Yep.
It's right beneath your clavicle.
Yep.
So those two ligaments come up from there, then you have your AC ligament that comes across.
Okay, so a separation is an eruption of which of those ligaments or all of those ligaments?
Well, so if you want to go through it, there's six of them, and so separation, the first one is the AC ligament. It's just a sprain,
Right.
and it's pretty good. That's a grade 1. A grade 2 is usually that the AC is completely torn, and then you have partial tearing of your CC ligaments, and then usually you get a grade 3. They're all somewhat torn, and you start maybe involving the deltoid trapezius fascia. And then when you get 4, in theory, so a grade 3 is up to 100% separation.
Right.
A grade 4 is where it's posterior. A grade 5 is more than 100%. Usually people say it's around, it's more than 100%, but something like 300% dislocated. Gotcha. And then grade 6 is the one that people talk about. I don't know if anyone's truly ever seen it, but where the actual clavicle goes underneath the coracoid.
Holy smokes.
Yeah, I feel like I've never seen one. I feel like people talk about it.
That's a lot of force, and like localized force.
Yeah, it's got to be inferior, which is a weird kind of way to happen.
Yeah, and not enough to impact the entire shoulder, only the clavicle.
I mean, what I'll tell you is, things constantly change. I always tell people all the time, I'm like, pick a year and think. What I tell you is 1 and 2 never need surgery. 4, 5, and 6 we always recommend surgery. Grade 3 is the one that kind of like that people go back and forth with. And I say, look, nowadays with Google, everyone's Dr. Google. If you Google grade 3 AC separation, or just AC repair in general, you'll probably see 10 different ways to do it. I would say, look, if there's 10 different ways to do something, that means that one way doesn't work better than anything else.
Yeah.
So I don't know. Again, with grade 3, I go through with people. I usually try to. It depends on the person because everyone's a little bit different. Like, I have a very bony clavicle, so I feel like you can see a lot of stuff. Some people have kind of like just shoulders are different. You might not see the deformity. So again, some people get it done. They don't like the way it looks. I don't think that's the reason to have surgery, but some people, again, I understand you don't like the appearance of things. But I would say it's based on your function. And so again, the literature kind of goes back and forth on grade 3s, and
what is the surgical procedure for that? Like what would you do in the clinic, in the OR type thing?
So the way that I do it, there's 2 main ways to do it. You want to stabilize that joint, and so there are various ways to do it. So you can take, some people do it open, some people do it arthroscopic. I do it like I call it an arthroscopic assisted procedure. Okay. So when we talk about an arthroscopy, we're talking about, I always tell people, I'm like, look, in arthroscopy, it's literally a camera the size of a pen that has it's the end of the pen, and so I can see inside the shoulder, and that it's usually at like a 30-degree angle, and so you can kind of spin the pen around, and you can see everywhere you need to see. And the way that I do it, at least with this one, again, not to be overcomplicated, is you use a 70-degree scope. So instead of a 30-degree angle, it's a 70-degree angle. It's just easier to see kind of around the corner. And what I do is the way that I just think it's best, and it's somewhat new. And it's not that I designed this myself, but I took 2 existing products and used it in a way that no one's ever used it before.
Okay.
And so what I do is, the product I use, it's you drill through the clavicle,
okay,
into the coracoid.
Okay.
And so what you do is then you pass up, it's like a button fixation. And so one of these buttons goes underneath the coracoid, and then the other button goes on top of the clavicle, and there's suture between them. And what you do is you reduce it. You can use an X-ray in the OR, you can use it by feel. And you reduce it until it's anatomic, and then you tighten it.
Interesting.
And so it's arthroscopic, but it's a little bit open because you have to make an incision on the top of the shoulder where you put the button on top. Well, to drill and put the button on top.
Interesting.
Now it depends on if it's acute or chronic, because then if it's chronic, which people usually say maybe around 4 weeks becomes chronic. It depends on different people have different parameters on when they are considered a chronic injury. Again, this is very challenging because it's easier to fix a broken bone. But the problem with this is all the muscles want to pull the clavicle up.
Sure.
And all the other muscles want to pull the shoulder down. So you have the forces that are pulling everything apart.
Yep.
And so that's why there's a lot of different ways to do this, because there's a lot of failure.
Sure.
And so if it's chronic, what you can do is you can pass a graft, which is usually some some tissue, and what you do is it's usually a hamstring, but you pass it around your repair, so it's almost like belt and suspenders. You got.
Interesting.
So I still do that arthroscopically though.
You would do that after the fact, or you would do it all at once, right?
So you do it all at once. So you pass the button, and then after you pass the button, you have to pass the graft. And usually, what you do is you pass everything, and then you tie everything. The graft part is a little bit challenging, but.
Sure, I mean, that makes sense. It's a unique, in my opinion, it's a unique ligament, I guess, because there is some motion that comes from that joint, right? Like,
but it's hard though. I remember,
it's not easy. I would imagine.
One of the first ones I did in practice, I remember the kid didn't seem to want to do it. It seemed like his dad wanted him to do it.
Yeah.
And the kid wasn't. I mean, he could make his own decisions, but I think he was 19 years old because he worked. He wasn't in school, and I told him, I was like, look, I don't know if it's a good idea. Like, again, I tell people, look, they'll scar in, and if it scars in, you'll be fine for most of them. It might look funny, but if it scars in, you'll be perfectly fine for the vast majority of things you do. Anyway, the dad, I think, sort of pushed him into doing it, so the kid signed up for surgery. He came in his first post-op visit without a sling. I was like, dude, what are you doing? He was like, what? I go, it's gonna fail. I told you, if you don't wear the sling, it's gonna fail. He's reluctantly sort of wore the sling, not really wearing the sling. He came back in at 6 weeks out. I go, still know without a sling. I go, it's already started to fail. He's like, well, I go, what are you doing? He's like, whatever I want. I go, well, he's like, what do you think I should do? I go, you might as well just do whatever you want now. I said, it's already, and by 3 months, it's completely failed. And I go, well, look, now you got a scar and it looks funny.
It's so tough for you, man, because that's some would see that as like, oh, he's ruining my work, And
it's hard, but I guess in hindsight, it was early in my career. I should have maybe had better foresight to be like, look, dude, like you either do the surgery and you follow the directions, or don't do it. Like, why? Like, I should have been like pulled him aside and been like, look, if you don't do it for your dad, if you don't want to do it, don't do it. But
right, if you're not going to be compliant, don't waste your time or my time.
Yeah, because again, now it looks funny, and you had it, and you got a big old scar.
Interesting. Yeah. So I had a grade 3 separation. We've seen it in the clinic all the time, and it's interesting in that essentially this ligament, like the clavicle, more often than not, like you said, it elevates, it ascends, and so you think you got to approximate these two, right? It's almost like anyone who's had an ankle sprain. Almost everyone rolls their ankle. You have two bones, at this outside of the ankle, and that ligament. When you roll it, you get the big softball, and then you get the bruising. Well, that ligament's only going to heal if you don't continue to have your ankle turned in all the time, right?
Yep.
Like it needs to be stabilized in an air cast, and walking fast or running or jumping is going to irritate that ligament. So you need those two bones to stay close to each other so it can heal as much as possible, right? The reality is that's a static stabilizer that really isn't gonna it's not gonna fix itself completely.
And again, the ligament's never gonna look normal. You want it to scar. And I mean, I said, look, I'm putting it back so it can scar in the appropriate position.
And so bracing for something like that, if there was an athlete of some kind, I'm sure this happens in the NFL all the time. Typically, it's a downward force on the shoulder.
So usually what happens, I always tell you, it's usually hockey or football tackle.
Yeah.
So what you do is you land on the side of the shoulder, and like your shoulder, your acromion gets pushed down.
Yeah.
And it's the force of pushing the shoulder down and everything stays. That's what tears everything.
Right. Okay. Interesting. And bracing for that same type of thing, would you use the same labrum brace for that?
Yeah, most everyone gets it. You get a pillow you get a sling with a pillow underneath it. You see, most people, if you watch on the sidelines, you can see some guy with a sling with a little pillow underneath. That's usually what it is.
Gotcha. And so, what is the most likely way a instability injury occurs? Right. We talked about the downward force on the acromion.
So if you're talking about like a true shoulder dislocation, it's usually like the at-risk position is the arm. It's almost like a throwing position. You have your humerus or the top of the bone is parallel to the ground with it's like if you imagine throwing a ball, and that's kind of the at-risk position. So I always tell people it's like whether you're going up for a rebound, whether you're throwing a ball, whether you're trying to catch a ball, like that's where the shoulder's going to pop out.
I think there's a Drew Brees YouTube video out there somewhere. James Andrews has probably played it a million times, but if anyone wants to see it, and Baker Mayfield obviously went through it in same position. He was reaching for the ball that he had fumbled. He was inverted. He was upside down, reaching for the ball in that externally rotated or throwing position. I'm curious about your take on mechanics. Like you had told me earlier, you mentioned earlier, like rotator cuff. I don't really do a ton unless they're over a certain age. Like so in sports injuries, you don't do a ton of rotator cuff.
There are typical rotator cuffs. without again being boring people to sleep, is that there's a natural. I tell people, look, there's two types of rotator cuff tears. There's your I call it the gray hairs and wrinkles of the shoulder. So if you get old enough, you're gonna have a cuff tear. So I would say it goes up by decades. So pretty much by the time you're getting your 50s to 60s, you've got about a 50 to 60% chance you have some element of a cuff tear. You just don't see it. So usually, like in your 30s, 40s, it's slim to none. So you have your gray hairs and wrinkles, your atraumatic cuff tears, then you have your traumatic cuff tears. But it's usually, for me, it's like someone slips on the ice or someone falls down the steps. I saw a woman today who I think has a cuff tear. She went to fall down the steps, grabbed the banister, and had her kind of pull their shoulder. Most of the cuff tears that I'm seeing are 40s, 50s.
How often, and again, I don't have a ton of experience with this, but like overhead athletes, like a thrower with a cuff injury, usually I would imagine like supraspinatus, right? Like something.
So here's what I'll tell you. Yeah. Cuff repairs, and I don't think I'm saying anything that's violating HIPAA, but I will tell you, when I was in my fellowship, there was, at least I'll give the sport, he is a current Hall of Fame hockey player. Yeah. Was in clinic. It was the one, I don't really get too much kind of like, oh my God. I will tell you, at this point in time, I was like, oh my God, this is amazing. Because I remember my mentor, he was like, I was like, I'll just stay in the hallway. He's like, what are you talking about? He's like, you're my fellow, you come in the room with me. I was like, okay, I'll come in the room. And so,
and you're a hockey guy, so
and I'm a hockey guy, so this is pretty awesome.
Sure.
And so the guy, again, I don't think I'm giving away anything, but my mentor always has, every guy takes his shirt off. That was how he did the exam, and he had a tattoo of when he won the Stanley Cup. I was like, oh my God, this is amazing. But he had a cuff tear, and what he told me is he said, and he was there for another opinion on what he should do with his cuff. He said, finish your career, then have surgery. No professional athletes ever come back from a cuff repair.
Interesting.
So since that, I don't know what Colby Bryant had done. I know Colby Bryant had some rotator cuff procedure. Mm-hmm. He's the only professional athlete I know of that's ever had a cuff procedure and come back. Now, I'm not saying that other guys haven't. I just obviously don't know every professional athlete, what shoulder surgery they have.
Right.
If you're talking hockey, you never even know. You're talking upper or lower body injury. Half the time they're lying anyway. Football's the only one where they sort of go into it. So yeah. I think there was someone for the Eagles that maybe had a cuff repair.
Might have been.
But I honestly, unfortunately, rotator cuff is a hard surgery to come back from.
Sure.
So, for an athlete, it can be definitely career-ending, more than any sort of Tommy John.
Yeah, I've seen a handful of them in people 50s, 40s, 50s that like CrossFit. I see, one way or another, and then they'll do great. Like their rehab is like unbelievable. It's like I'd see it 2 years later. You know what I mean? It's like, what did you do? I was like, I was doing whatever I was doing.
It's funny you say that because I have a woman right now.
Exercise or something.
I have a woman right now who, she is a competitive lifter. I know there's different classifications, and I don't know them well enough. But she is jacked, and she makes me look like I've never worked out in my life. So she was exactly what you just said. She was doing a snatch,
yep,
and dislocated her shoulder. Uh-huh. And I was like, so we got an arthrogram. I was like, she failed, and she was, again, extremely competitive. She's international competitions, and so I treated her like a professional athlete, not like kind of your weekend warrior. And so it was one of those where I was like, all right, I don't remember even when we did therapy, where she's like, I need to be like normal. I lift heavy weights. I get back, and I was like, all right. So we got an arthrogram, labral tear. Again, this is the other thing I tell people all the time. I was like, MRIs are good. They're not great. They're not 100% accurate. People think it's an MRI. I said, yeah.
You go in and you may find some things you
100%. I mean, MRIs can be wrong. I mean, up to, probably 10, 20% of the time. And so I went inside the shoulder. She was 41, 42. She was probably going to be my oldest instability procedure. You just don't usually do it on someone that age.
Right.
But I was like, all right, she's different. She's not your average person. So I went in to fix her labrum, and I got in there, and I was like, the labrum didn't look bad. Her cuff was hanging on by a thread. Like, wow. It was pretty much a complete tear as far as I was concerned. And I was like, I'm not doing the labrum. The labrum's not her issue. She's never going to be able to power lift again with her cuff like that. And so I sort of sidetracked. I fixed her cuff. She made a full recovery. She won like her next like international world competition. And I was like, well, that's kind of awesome.
Yeah, right. Can I get that plaque in my office?
It's funny you say that. She literally was doing awesome. I just saw her back. So I fixed her cuff like 4 years ago. She came back a month ago, and she was like, I was doing some clean and jerks, and I did something. I tweaked something, and I've been doing the cuff exercises that I learned in therapy for my recovery, and it's just not better. So I'm actually she's getting an MRI. I'm waiting to see her back and see what it shows, but I'm a little nervous.
I mean, and I would say, okay, what about that snatch what happened during that snatch, right? How many times have you done a snatch? What happened that time?
I mean,
to find a dynamic stabilizer that wasn't, the integrity was affected.
I mean, I also tell people, I'm like, look, I don't know if you've ever done those kind of exercises. I hate doing the Olympic lifts. We had to do it in college, and I was like, look, it's all form.
Oh yeah.
It has zero to do with how strong you are.
Yeah.
I mean, again, I guess that's a part, but if your form isn't perfect, you're gonna hurt yourself. So it's like one of those things when I used to do them because we had to keep our little log books for lifting, and I was like, if I wasn't feeling it, I'm just not even doing it. It's not worth it.
It's not worth it. Without a doubt. I saw it all the time.
But it's also, even then, again, it's one of those slides. I have an elbow instability talk that I give, and I usually I'll alter the picture, but it's usually all the same person. It is an Olympic athlete who dislocates their elbow doing a snatch because and these guys are obviously the best of the best, and they still have serious injuries. But you know, when you're lifting that kind of weight, you are off just a hair, and you're in trouble.
That's all it takes. Yeah. That's all it takes. There's so many factors: sleep, a diet. There's, that could affect.
You're going for 2 extra pounds than you usually did, and the weight you lose it a little bit, and you're in trouble.
It's the 10th rep, whatever. You forgot your chalk, so you had to use someone else's chalk.
Yeah. Once I graduated college, I was never doing one.
Actually, me too. I played football in college, and like those types of heavy like power cleans. Again, I get that people that still do it. That's good for them. I just can't.
My only sickness is I can't stop heavy squatting. I don't know why.
No, that's like a pride thing. I think
100%. I want to stop though. I'm definitely down from COVID, but I want to stop because I just want to, not because like COVID made me. Because I didn't work out for 2 years.
There's something about having 3 or 4 plates on the bar, and you're like, yeah, I'm getting parallel.
Yeah.
100%. I don't know.
But again, not to go back to my wrist, but I've never been able to really bench press since I broke my wrist.
Well, I think, I'm a firm believer of, I think bench press is one of the, I get it's a measure of upper body strength, all that. There's so many better things you could be doing for your upper body strength than freaking bench press. And I like overhead throwers, no reason to bench press. We talked about it in previous podcasts. Like, stay away from bench press. It's not going to help you.
As I said, there are 2 terrible things for shoulder press and bench press.
Right. And because, for so many reasons, but especially the cuff.
I saw a guy today who was a cop, and, he did have a work injury. But I told him, I said, but he's got a posterior and a superior labral tear. And I was like, look, I think the superior labral tear is probably from the work injury, from the mechanism he told me. The posterior labral tear, he's a pretty jacked dude. I'm like, any guy who bench presses probably has a posterior labral tear.
Oh yeah, just the amount of force that goes through that part of the shoulder,
100%.
When you're holding up that kind of weight.
Yeah.
And not to mention how you bring it down, how you bring it up, the amount of pace you use. No, you're right. That makes perfect sense. What am I missing? What else do you want to dive into? I know we've been.
I'm gonna whatever you want, man.
I'm trying to think.
I guess we already talked about it, but we talked about it, before the podcast. Was people get a little bit intimidated about seeing a doctor, and I can't sit here and tell you that everyone's the same. So there are different groups have different philosophies. I can only speak about me personally, and our group is yes, I am a surgeon, and yes, but my job is to get the person back. And so I would say, look, I don't have a non-operative person, so I'm the only person there. And again, people are like, if I think you need surgery, I'll tell you need surgery, but there's very few things where I'm going to say you need to have this fixed. And it's usually not a sports issue. It's usually my massive cuff person who I say your best chance of doing well is to have it done acutely rather than rehab. I guess this is applicable for my weekend warrior is if you tear your cuff, like let's say you play football with your buddies and you dislocate your shoulder. So usually shoulder dislocations, teenagers, 20-year-olds, you tear your labrum. I tell the fellows, you're 40 and over, you dislocate your shoulder, you have a cuff tear till proven otherwise. So if you're 40 and so if I'm 43, if I dislocate my shoulder, I'm getting an MRI because I have a cuff tear till someone else tells me I'm not, because I'm not. The cuff is the weak link, not the labrum. And so those that I say in acute cuff tear, fix it. And fix it immediately, because that's your best chance of doing well.
What happens if you don't fix it immediately?
The problem is, again, if you look at, if you're going to say what's the bane of existence for a shoulder surgeon, it's rotator cuff repair, because you're better off breaking the bone. That heals more predictably than your cuff. The biggest complication is a cuff tear is it doesn't heal. Now, studies show that they don't all have to heal for patients to do well, but that's the biggest problem. And we know that the best chance of you having a successful surgery is to have it done. It doesn't have to be like tomorrow, but usually within the first, 6 to 12 weeks.
So at the surfaces of the tear, and I know I'm going back into tears again, but at the surface of the tears, the approximation of the tissue, how challenging is that, right? Like, let's be honest, like if it's not getting adequate blood flow and it's not completely connected, right? Like it turns to like adipose tissue or fat, right? Or it can retract if it's a complete tear. Yeah. So how does that make your job difficult? I
mean, it's interesting. So the ones that I hate the most are the small tears, because it's hard to see and it's hard to kind of get them perfect. We often talk about, like, it's interesting how your body is, because you have this sort of the cuff tear, or the cuff is not straight across where it attaches. It has this kind of curved shape to it. So when it tears and you try to repair it, it's very challenging if you haven't tried to sew like a curve and get it to be flush. It's very challenging not to have sort of dog ears, as we call it.
Right.
So honestly, these small tears are hard. Honestly, the easier ones are these massive tears, because I can kind of put it down wherever it fits the best. I can see easily. It's the small one that's kind of hard to see. So it's much easier to do a massive tear than a small tear, in my opinion.
Gotcha. I would think, I've heard surgeons say it's like sewing two pieces of tissue paper back together. Like, it's just.
It all depends. Again, it depends on the person, but
right.
If you do it acute, again, the reason is soft tissue to bone is just, it's hard to get things to heal. And people say it hurts, and honestly, the reason it hurts is because what you do is you take a burr, and you're taking it to the bone, and you're decorticating, you're taking off the top few layers of bone.
Right.
So really I'm fracturing your bone.
Right.
Because I want it to bleed, because you want it to heal.
Yeah.
And so people are like, God, this hurts. I'm like, yeah, it's because reality, you're breaking the arm to get it to heal.
Right. That sounds pretty brutal.
So it hurts. So, but that's the cuff. It's kind of is healing is the issue. That's why you want to do them acutely. But in terms of, as we talked about, I was like, look, I try to say, like, yes, I'm a surgeon, but my job is, again, as I think I mentioned, is to get you to make a good decision for you. So not everyone needs surgery. I have plenty of people who have full cuff tears, and I personally think they should have it fixed, but they're like, I can do everything I want. I was like, all right, as long as you know that there probably will become a point in time this cuff isn't fixable, you do you.
I'm with you on the acute cuff tears, because I've seen that people who wait and then get it done now have their motor controls completely off, because their biomechanics have been off for so long.
100%.
So now they're not able to recruit like lower trap or some of these other muscles that are all supposed to help, support the cuff.
Yeah.
And they just don't. And now they're just so deltoid dominant or so trap dominant and so forth. And they just, they're inhibited from using those muscles because they.
Well, yeah. Then you got the scapula off, and like the bane of my existence, your existence is any sort of scapular stuff. It's just like
it's miserable.
It's like scapular dyskinesia. I'm like, yeah, it's like kind of garbage pail to diagnose. No one wants to deal with scapular dyskinesia.
Right. And how much is normal? Like, there was a podcast the other week I listened to. It was like, is it normal to see a baseball player with that, right? And then you release the lat, like you dig into the lat, and now it moves normal. You're like, oh, great. But then they hurt themselves the next week because you just threw their mechanics off. That was like, it was. They got used to it, right?
Yeah. Well, it's the whole the GERD and the rotation deficit. It's like you got these professional athletes who've obviously gotten to where they're at because they've altered their mechanics so they can get this external rotation. But now we're trying to make sure to get it so it doesn't normal, and then now their throw mechanics are up. It's hard.
To identifying the dysfunction, right, is always challenging. But you got to do your due diligence, and from a PT perspective, you got to go through all of it. Assess all the muscles and see how it moves. Watch the individual do what they do that hurts, right?
Yeah.
If you can.
Go
ahead.
No, that's what I'm saying. But again, for like the average person, it's like, it should be. Again, not every doctor is equal, but. For me, at least, my job is to sit here and kind of have a conversation and what makes sense. And I tell people all the time, I was like, look, come with questions. I'm fine with questions. I write them down. I have zero problem. We'll do through question by question, because you're forget, and then you're going to be, oh my God, I should ask that. I was like, bring your questions. any doctor who doesn't want to have time to answer your questions, or I tell people all the time, because people want to, if they want to, if you want to get a second opinion. I mean, if someone is confident, I'm sort of saying for therapy, I'm confident in what I'm telling you, and any doctor who says don't get a second opinion is a doctor you should stay away from.
That's a great point. We had spoken right before the podcast about how I see patients and like, I don't want to see a surgeon because surgery is not an option. It's like, you don't know what you're getting into when you see a therapist. Like, is going to be manual therapy, is going to be exercises, is going to be a combination of both. I'm curious, and I think that's kind of the case or direction you were going with this. I'm curious what your philosophy is in terms of, okay, what kind of services can you provide or direction you can provide that someone who is sports medicine that's not a surgeon, right? Like, why see you? Not necessarily not see them, but why see you? Why
I think
are you
it's
still
different.
a good option?
I think the difference for me is I come from both avenues. So my job is I have plenty of patients. I don't operate on every single patient, so I can help them, direct them in the non-operative treatment arm. And there's not a knock on the sports guys, but as a surgeon, you just have a better knowledge of what's going on anatomically, because again, not to knock my sports colleagues, but most sports colleagues aren't doing 5 years of orthopedics and then a fellowship and then training. Most sports doctors are actually doing some sort of general medicine, and they're doing a 1-year sports fellowship, and that's their orthopedic training is a 1-year fellowship. So I'm not saying that they can't get there eventually, but most of them it takes a lot longer. And so for me, I did 5 years of orthopedics, and I just have a broader depth, a deeper knowledge of what's going on. And then as a surgeon, I know what's going on anatomically from a surgical standpoint, so I can kind of speak to both arms. Because the problem with the non-op guys is, if you fail non-op, we're like, okay, we'll see the surgeon. And a lot of people don't want to see the surgeon day one and be like, hi, my name's Bob. And you're like, yeah, you need surgery. Here's the consent. See you later. You don't have a relationship. So I think more people are more comfortable with someone they've developed a relationship with.
Yeah, and I think in the end, what I've learned in my experience is that depending on who it is, and everyone's their own person, your job is to guide their recovery.
100%.
Right? So if it's and who's best at doing that, I don't know if there is a right answer to it.
Everyone's different, and some people are perfectly fine with seeing the surgeon the day one. And I'm not saying there's wrong. I mean, some people, if they work for them, great.
Yeah, I think guiding and facilitating someone's recovery, whether it's through the tools that you have in your toolbox or sports med that they have in their toolbox, in the end, you got to work with somebody who has your best interest in mind and who knows what you have to do to get back to doing what you love to do and playing sports or whatever it may be.
I got a question for you.
Shoot.
All right, this is something I've always wondered. It's like the bane of my existence.
Let's hear it.
What is the point of the arm bike? I think it's the worst thing ever.
Do you see one in here?
I don't know. I didn't see one. I was trying to look without. I don't understand it. I don't get it. I hope my colleagues may hate me for this. I'm anti-machine. Like I don't like machines. I think people can get hurt on machines. The upper arm bike. I was talking all the time.
I don't have a good reason why it's in the clinic.
I was like, at no point in your life do you ever run with your arm. So why all of a sudden were you going to take some usually middle-aged person who had some sort of may or may not have surgery, you're like, let's put him on an arm bike.
Oh wait, here's the worst part. Where's the seat relative to where the pedals are? So Isabel, I don't know if you've ever seen one of these, but essentially it is a bike where you do, like it's not a
I
bike
just don't
or whatever.
get it.
So I'm putting you in an impingement position. I'm probably going to put you on this because it's for your upper extremities, because you're here for your upper extremities. So let me just do you a favor and put you on a bike that's going to irritate everything in your shoulder, right? Like it's just...
if you want to get warmed up, like stretch. Like you don't have to go on be like a mouse on a hamster wheel.
Oh my god!
I just never understood. Funny. I literally every time I see a patient, I'm like, how's therapy? And on my end, therapy is challenging. I'm seriously on your end.
Please open up about it.
Well, because half the time people are like, oh, I don't want to go to therapy. I'm like, you just dropped $1,000 on your new phone, but you won't spend $1,000 on your body. I mean, it's just like I don't get it. I understand things are expensive, but your body's the most important thing you have. I just don't understand why people won't do therapy.
Because one bad experience, and usually that's part of it. The other reason is because how do I say this? I don't want to offend anyone, but essentially what happens is people want to know what they're getting for their dollar, right? So I know when I buy this phone for $1,000, I know what I'm getting in my phone. When
you also you have the instant gratification of with therapy. I'm like, all right, I go there for 6 weeks. I'm like, yeah.
Correct, right. And it's a process, right? You're investing in a process. You don't know what the outcome of the process is going to be. It may cost you a lot of money. Copays $80, $90 sometimes. Your deductible, you may have to pay towards that. It could be very expensive. You don't know what you're getting out of it. Unless you've had a really good experience and you have someone you trust, you go back to them. I think that's probably more likely the case.
Yeah, I mean, the ones that I find are usually they don't like, and again, there's different philosophies, and I'm sure you guys have different philosophies, sure. But they don't like, well, I go there and they show me some stuff to do. I sit in the corner and do it by myself. I can do it at home by myself.
And to me, that comes down to value. Like the PT should be asking that individual, what do you value most? Right. I've had patients come and be like, listen, we got to do as much manual therapy. I'm like, I want to go work out, right. Dude.
But I tell people all the time, I go, look, I have a home program I can give you, but go see the therapist at least once to make sure, because I don't have the time to go through each exercise. Go see the therapist. That is their job, and they will take you through each, even if you go once. Pay the $40 copay. I had a woman today. She's like, you know what? That's great. I'm going to go once. I go, yeah, learn the program and then do it on your own.
And when someone calls in and say, yeah, my doc said I can come once, and I feel like some PTs are going to pull their hair out listening to what I'm about to say. And they say, oh, I'm only going to come once, and my doc said I could do that. And they're like, no, it's probably going to be more than that, but you should come in anyway. They're not going to come in. Get them to come in. Ask them what they want. What value can you provide? If it's one visit, and maybe I've had patients that said, you loosened me up more than I thought you could. Can I keep coming?
Well, that's what I was getting at, because I say that because it gets them in the door.
Right.
And usually most patients, I was like, oh, did you do the home program? Like, well, I went that one time and it was much better than I thought, and then I ended up going, because that's usually what happens, is they go once and then once turns into like, well, because then I'll say, well, go once a week maybe, and they can at least make sure you're progressing. And then it becomes, well, okay, I went twice a week.
Yeah, whatever they value. And again, you offer education. If you come in twice a week, you're going to get there sooner than if you come in once a week or 3 times a week, whatever it may be. But, it's not about, I've seen people in corporate, different companies push numbers and agenda, and I'm sure you know what it's like. But in the end, being a good person, a people person, and giving them their options, that's what people want. They don't want a million options. They want a couple options.
Yeah, but then usually the patient will come in, and if I don't feel they're progressing, or they're like, they don't like the therapist, I'm like, well, what are you doing in therapy? And when they mention, I was like, well, do the arm bike. I'm like, all right. I was like, well, either A, don't go to that therapist, or B, I'll write in the new script. I was like, no arm bike.
Yeah. I'll make sure that doesn't happen. I'm anti-arm bike. I've never.
I just don't get it. Again, I'm not being a therapist. It's one of the things I just don't get.
But here's the thing, though. It is like protocol. In any new clinic, you will see,
I see it everywhere.
Any clinic. I mean, they're like, it's like a staple of the clinic, like a treatment table. If there's going to be a treatment table, you're going to see an arm bike and a treadmill. It's and a recumbent bike. I hate recumbent bikes. That's like a leg press bike. You leg press. It's something.
But I get a treadmill because everyone walks on their legs.
Correct.
No one walks on their arms.
Right. Yeah, I'm just like anti-traditional PT stuff. You won't see leg press or leg extension or leg curls or pec stuff. You go to Planet Fitness and do that stuff, and not here.
I hear you. I had asked.
Sorry, you got me going now.
Planet Fitness does have an arm bike.
Oh, I know. Listen, Planet Fitness is great, and if you want to do that, that's fine. To me, I don't know, a therapeutic and arm bike.
As long as you're not yelling or whatever that tagline was.
No grunting.
No,
lunk alarm.
Lunk. That's what it was. I was to say hunk. It's not a hunk.
I say all the time, there's no lunk alarm in here. Go ahead, you grunt.
You do your thing.
Is that everything? Anything else you want to go over?
I think so, off the top of my head.
This has been awesome.
Man. I had a good time.
All right, cool. Well, until next time.
Absolutely.
All right, cool. Thanks for joining us, Doc.
Thank you.